Hey guys, welcome to the OMT review videos. This is for the 3rd and 4th year clinical skills review. In these videos, we're going to take you through multiple body regions and joints, and we're going to be talking about how you would osteopathically assess these areas as well as some ideas for OMT. We will not be going through all the phys die for these areas. Please refer to our other worksheets for that. And again, this is not meant to be comprehensive, but more just ideas for you to get your kind of mind thinking for the PD. So the first area we're going to start with is going to be head. So you would want to assess the head if you have a patient that comes in with complaint of headache, congestion symptoms, upper respiratory infection, runny nose, ear pain, that sort of thing. So the way that you might assess it would be just something as simple as sinus tenderness to palpation, so for the frontal and then the maxillary sinus. And if there was some tenderness, we could treat that with just sinus pressure and milking. A little bit of pressure and then moving your fingers out laterally for the frontal as well as the maxillary sinus. Another technique that we could do would be gall breaths. I'm going to come over to this side so that you guys can see. So remember, you have your patient kind of look a little bit towards you, open their mouth just a little bit, and then you want to contact the posterior aspect of her mandible. I can just kind of hold onto her head, stabilize with my right hand. I'm going to grab her posterior mandible and then just kind of traction it towards me. Just like this. And you would probably want to do both sides, but I'm just going to show you that side for the video purposes. And another one technique that you can easily remember would be that pre and post auricular. So remember, just 2 fingers in front of the ear, 2 fingers behind, going in a clockwise direction, or counterclockwise, and then clockwise. And again, you could do this to both sides. Then I would help my patient up always. So the thing that you might want to document in the O portion of the SOAP note for head might be something such as sinus tenderness to palpation. And then in the P portion of your note, make sure that you mention lymphatic techniques to the head. Thank you.
Hello, this is the cervical spine OMT diagnosis and treatment video. We will be going over just diagnosis of the C-spine and then what are some suggestions for treatment that you might do. So first, or whenever you have a patient who comes in with either neck pain, headache, whiplash, or even torticollis, those can be indications for OMT. And to begin, we're going to do some gross range of motion. So we have our patient flex forward and then extend their head back and rotate to the right and to the left, side bend to the right and then to the left. Good. Then we can have our patient lay down on the table. We're going to do our segmental diagnosis. So we're going to come down to the base of the neck, find that C7 prominence, and then move out laterally. And we can check our rotation by pushing straight up to the ceiling, working all the way up the spine. Then we can also check inflection. And then we can check an extension. And then we also want to assess side bending in neutral. And that's where you just come out just more laterally onto the spine and check inflection. Extension. And then let's say I notice that her paraspinal muscles were hypertonic, so let's do some soft tissue for those. We can do our supine cradling with traction, where we start down at the base of the neck, and then in kind of that wave-like motion, just move all the way up. You can kind of watch their chin rise and then dip back down as you do this. Do that for several rounds. And then next we can do our suboccipital release, everyone's favorite. And that's where you're going to put your hands into that kind of L shape, and your fingertips should be right at the occipital sulcus. So we pick up the head, get our fingers situated, and tell our patient to relax. And you'll notice that their head falls back into your hands. We hold that till we feel the muscles relax. Then we can gently set the head back down, and we're going to reassess and see if our soft tissue treatment helped. If you find a specific diagnosis, let's say C3 is rotated right and side bent right, we can do some stills technique for that. So you come and you monitor at that segment with one hand, and then with the other hand, you rotate right, side bend right, where it likes to go, add your compression, and then move their head over to the barrier. And then if it doesn't resolve with one, you can always try again. And feel it go, and then gently set their head back down, and then reassess. And when you're done with that, you can help your patient up to a seated position. And then for documentation, you're going to be putting your specific somatic dysfunction, either muscle tension or like C3 rotated, neutral, rotate right, side bent right, in the objective portion. And then in the plan portion, you're going to put soft tissue and stills performed for the cervical spine. Thank you.
Hi guys, this is the thoracic spine video. So some reasons that you might assess a patient's thoracic spine would be if they come in for upper back pain, middle back pain, and remember you can also check this area out for viscerosomatic levels. So first we'll have our patient flex forward, checking gross range of motion, and extend back, side bend to the right, side bend to the left, and then the major motion of the thoracic spine rotation. So rotate to the right and rotate to the left. Make sure you note any restrictions there. So then to assess our patient's segmental motion, you can do this part seated. Some of you might prefer that. I just prefer the patient to be prone because I'm more confident in my diagnosis. So again, just finding that C7. And then I'm going to find T1, come out just laterally, and I'm just loading and springing on the right and the left, remembering that the spine of your scapula is at about T3 and the inferior border of that scapula about T7. So again, just loading and springing, looking for any restriction of motion or ease of motion. You can also kind of follow your floater ribs 11 and 12 and find out where they connect, and that being your T11 and T12. So if I found a dysfunction about T3 to T7 on the left, rotated left, I'm just going to assign my side bending knowing that this is a type 1 dysfunction. But now I just need to make sure and test it in flexion and extension because it can be a stacked type 2 dysfunction. So I'm going to have my patient get into TV watching position to go into extension. Checking to see if that got better or worse or stayed the same. And then cat back position for flexion. Good. All right. So we still have a type 1 dysfunction. So the first technique that I'll show you guys would just be some soft tissue. So we'll just do prone pressure. Remembering to find the spinous process and just move out laterally. You can do it with 2 hands or just stack one hand on top of the other. Trying to keep your arms straight and really loading into your thenar and hypothenar eminences. And then it's just an anterior pressure with slowly moving out laterally. So this is more of a perpendicular stretch. You can do it parallel by just moving in the same direction as the muscle fibers, or you could do prone pressure with counter pressure going the opposite way. Remembering to wait for that muscle creep or tissue creep. So there's our soft tissue techniques. Then I'm going to help my patient up. And we'll do a muscle energy technique. So she was rotate PTP on the left. So this is a type 1, so I'll have her put her left arm behind her neck with her right arm grab her elbow. Remembering that for type 1 we go under, over. Type 2 would be over, over. Then I'm just going to rotate her and side bend into the barrier. Have my patient go back to neutral. Isometric contraction for 2, 3, 4, 5, and relax. Further rotate her into the barrier. Go back to neutral. 2, 3, 4, 5. One more time into that restriction. Go back to neutral. 2, 3, 4, 5, and relax. And then I can just go ahead and reassess while my patient's in this position. So just make sure that in the O portion of your SOAP note that you make note of any specific somatic dysfunctions or TARP findings, and then in the plan portion we would just do soft tissue and muscle energy for the thoracic spine. Thank you.
Hello, this is the lumbar spine OMT video, diagnosis and treatment. So you can use this whenever you have a patient who has low back pain. And we'll start off with some gross range of motion, so have your patient stand up. And then ask them to flex forward at the waist. Good. And then extend back as far as they can. Good. There is going to be a little bit of linking. And then have them side bend to the right and side bend to the left. And then rotate to the right and rotate to the left. Good. And then for our segmental diagnosis, we can have our patient lie down prone. You can assess the seated if you're comfortable doing that. Okay. So to find the lumbar spine, you can either find the bottom of the ribs and trace those in to T11 and 12 and then come down to L1. Or you can start down from the PSIS and then work your way up. Whatever you're more comfortable with. So we check our rotation. And we can start off with our treatment with just some prone pressure with counter pressure. So we're going to come to the spinous process, move out laterally, and this is the one where you pick up their hip. And then you do kind of that ringing motion. You're just going to apply that anterior and lateral pressure until you feel the muscles relax. And then you can do that on both sides if you feel you need to. And then you come back and reassess. For muscle energy for the lumbar spine, we can use our NEUTR acronym, which is neutral, PTP is up, patient's activating force is down, and then it's in the lateral recumbent position. So have your patient roll over facing you. Good. We're going to find that PTP, flex the knees up till we feel motion, and then we're going to pick up their ankles and then have them try to put their ankles down to the floor and hold it for 2, 3, 4, and relax. Re-engage, and again, 1, 2, 3, 4, and relax. And again, 1, 2, 3, 4, and relax. Okay, then you have your patient roll back onto their stomach. And then you should reassess those PTPs. You can also use your SUI or your FDDR acronyms, but I'm not going to go over them in this video. And remember, if you are uncomfortable with using the acronyms, you can also use your lumbar muscle energy similar to your thoracic muscle energy. All right, then you can have your patient roll over and you can help them up. And then, as always, in the O portion, you document your specific somatic dysfunction that you found, and then in your plan portion, you'll write soft tissue and muscle energy performed for the lumbar spine. Thank you.
Hi guys, this is the hip and innominate video. So some reasons we might assess our patient's hip or innominates is if they come in for hip pain or even low back pain. So first we'll just do some range of motion of the hip. And remember, anytime we do range of motion for a joint, we want to do it bilaterally so that we can compare and assess for any restrictions or asymmetries. So first we'll do flexion, try and keep the legs straight. And then while we're here, we can do external rotation and internal rotation, trying to keep that knee bent to 90 degrees. And then I can do abduction and adduction. And then I'll have my patient flip over prone, and we'll do extension. while we're in this position, I can go ahead and check for innominate landmarks. So the one that's on the posterior aspect is that PSIS, comparing those heights. And then I'll have my patient flip over back supine. And I can do pelvic compression, ASIS heights, ASIS to midline. You can even check for pubic tubercle heights using the heel of your hand. And then last, medial malleolus heights. So after I've assessed my patient and have a dysfunction, we'll show you a few treatments using muscle energy. So we're going to first show you internal and external rotation dysfunctions. These are really common in patients. So let's say our patient had an external rotation dysfunction in that they liked external rotation and were restricted to internal rotation. So for muscle energy, I'm going to take them into that restriction of internal rotation, and she's going to try to come back into external rotation for 3, 4, 5 seconds, that isometric contraction. Then I'm going to have her patient relax, take her farther into that restriction of internal rotation, and then resist me for 3, 4, 5, and again, and relax. And then we would reassess. So now let's say our patient has an internal rotation dysfunction and that they like internal rotation and they're restricted to external rotation. So I'm going to take her into that restriction of external rotation and have her try to swing her leg into internal rotation for 3, 4, 5, and relax. And again, resist. And relax. And one more time. And relax. And then always make sure and reassess. So we showed you internal and external rotation dysfunctions because if I were to show you a flexion and extension somatic dysfunction muscle energy, that looks very similar to an anterior and posterior rotated innominate. So let's imagine that our patient has an anterior rotated innominate here on the left. So to treat that, I'm just going to bring that leg anteriorly. You can do this with the leg straight or with the leg bent. So I'll show you it with the leg bent. Taking her into that restriction and have her relax or resist me, trying to push against me. And relax, and again. And relax. One more time, try to push against me. And relax. So that, again, that was for an anterior rotated innominate. To do a posterior rotated innominate, to treat that with muscle energy, we're going to have our patient scoot to the side of the table. You might have to lift your table up a little bit. A good way to do this is kind of to face the same direction as the patient and have your guys' hips right on each other. So then I'm going to drop this leg closest to me off the table. This is the side with the dysfunction. I'm going to stabilize that other hip and then push down and have my patient try to push this knee up to the ceiling. For 3, 4, 5, and relax. Pushing it farther into that restriction and push against me. For 3, 4, 5, relax. One more time, push against me. And relax. Bring that leg back up to the table. I can lower my patient's table at this time. And I'll have the patient reset their hips. And then I would reassess my landmarks. So we've gone over assessment and treatment for the hips and innominate. So you would put any of the somatic dysfunctions that you found for the hip or innominate in the O portion, as well as any other TART findings. And then in the plan portion, we would just put muscle energy for the hip or innominate. Thank you.
Hello, this is the sacrum OMM diagnosis and treatment video. So sacrum can be a little intimidating, but we're just going to run through kind of the bigger topics of it really quickly. Hopefully some of it will look familiar. So you can use this for a patient that comes in with low back pain, SI joint pain, or even gluteal pain. And we're going to start first determining our laterality with our PSIS. This is our forward bending test. So find those PSIS and then have your patient bend forward and look to see which one moves first and farthest. You can come back up. All right, and then from there, have our patient lay down prone. And then we're going to go through all of our sacral tests. So you can start with the lumbar spring test on the base of the sacrum, and that's checking to see if the sacrum is held backwards in either extension or in a backwards torsion. We can check our static symmetry, so find our sacral sulci, which is just medial from the PSIS, and then work down to your ILAs and just look to see if there's any deep or shallowness to your fingers. We can check our 4-point passive, loading and springing on the sacral sulci, and then the diagonal ILA, then come to the other side and check. And this is checking for torsion. And then we can also find our ILA and then come just below that so that we're pushing its cephalad, and that's our side bending, checking for a unilateral. So for treatment of these, if you have a bilateral extension, remember you're just going to push straight down, and then with respiratory assist, try and push the sacrum back forward. And then if you have a bilateral forward, you can come to the apex of the sacrum and push anterior, and that will hopefully toggle the sacrum back into extension. For the unilaterals, it's pretty much the same concept, except you're just going to be on whichever side of the unilateral. So what I really want to go over is the torsion treatments, because those are a little bit more difficult setup. So let's start with our forward torsion. We're going to have our patient lying lateral recumbent, and then we're going to flex the hips and knees. And then you want them, remember, for forward torsion, have your patient going forward. So they're going to hug the table. This is our Sims position. And then we're going to drop their ankles off of the table and then push down till we engage that barrier. And then have them push their ankles up to the ceiling. Good. Hold it for 1, 2, 3. Relax and re-engage. And you're going to continue these steps for 3 to 4 times until you feel like it is resolved. Then you're going to reassess, but I'm going to jump right into the backwards torsion. So I'm going to show that for this angle. So for backwards torsion, you want your patient going backwards. So have her put her back against the table, flex the hips and knees, and then they can straighten out that bottom leg, and you hold on to the top leg and flex it until you feel a barrier. And then you're going to have her push her knee to the ceiling. Then hold it for 1, 2, 3, relax. Further push it down and push up. And relax. And then you're going to continue these 3 to 4 times. And then you can come back and you can reassess. So once you have done all of your treatments, for your documentation in your objective portion, you can put your specific sacral somatic dysfunction that you found, and then in the plan portion, you can write down muscle energy for the sacrum. Thank you.
Hi guys, welcome to the rib video. So we want to assess our patient's ribs if they come in with a cough, an upper respiratory, lower respiratory infection, any lung issue at all, even something like COPD, and remembering that a really great rib technique is the rib raising for lymphatics. So we'll just start off with assessing and treating the first rib. So remember to assess it for the bucket handle. It's going to be behind the clavicle, more lateral and posterior. And then to assess the pump handle motion of the first rib, you're going to come more anterior. So if my patient had an inhalation or elevated first rib on this side, I can treat it with muscle energy by just having my patient inhale and exhale, pushing that rib inferiorly with exhalation, and just do a few cycles of that. Another thing I can do is stills for the first rib. So if I was going to do pump handle, I could do a counterclockwise motion, looking down straight towards the patient, and then to treat bucket handle, going the opposite way. And there's 2 treatments for treating first rib. Then I'm just going to assess gross motion of the ribs. So you want to assess pump like this. You can come a little bit lower. Be mindful if you have a female patient. And then for more bucket handle motion, and then don't forget about 11 and 12, the caliper ribs. So we'll have our patient lie prone. Find our caliper ribs first, and then assess that motion as well, like this. While you're here, you can also assess for a posterior rib angle or rib head. I like to do that standing at the head of my patient so that I can actually do it on both sides at the same time to compare. You might feel as though your patient has a posterior rib angle, but when you look at the other side, it's symmetrical. So making sure that it's not symmetrical. So let's pretend Kelsey had a posterior rib angle. In order to treat that, stills is a really great technique for this. So you just find where you had that posterior rib head or rib angle, take the arm on the affected side, extending up to the level, compress, and then an overarm throw. You can even do an underarm back. And that's the ribs. And remember to document your rib somatic dysfunction in the O portion, and then muscle energy or stills for the ribs in the plant portion.
Hello, welcome to the upper extremity OMM video where we'll be going over diagnosis and treatment of the upper extremity. You can use this for any upper extremity joint complaint, so that includes shoulder, elbow, and then also wrist, and can also be used for carpal tunnel syndrome. So first we'll start with shoulder, and we'll do just kind of a quick active range of motion. Have your patient stand up, and we're going to do the Apley scratch test, so going one way and then the other, looking for any discrepancies there. And then we'll also do a passive range of motion. I'm just going to demonstrate on one side, but you should do both. So we'll check flexion, and then extension, then abduction, and then you can also check adduction horizontally. Then we're going to try our external rotation and our internal rotation, looking for any discrepancies there. Now our go-to treatment for any shoulder complaint is really Spencer's technique, and you do need to know the steps of this one, so we're going to go through those. You have your patient lying lateral recumbent, and you'll start with extension. So make sure you lock out at the shoulder, and you extend back, come out of it, push further into extension, come out of it, and you can just continue this probably about 6-7 times. Then when you're through with extension, you come into flexion. Flex them all the way up, come out, come back in, come out. And you just repeat this once again for the 6 to 7 times. Next, we have our circumduction, and that can be your with compression. You work in a either clockwise or counterclockwise direction, getting in a larger circle. And then you can do your circumduction with traction, working from a small circle into a big circle. Then you can switch to your abduction, make sure the patient doesn't hit their face, and then into adduction. So AB and AD. Okay. And then, once we're through with that, we're going to go into our internal rotation. And be careful with this one, as it can be very tender for people. And then we're just going to pull them further into internal rotation and out. And then after that, is our glenohumeral traction. So you put their arm on your shoulder, and you're trying to isolate to the glenohumeral joint. You're not pulling their entire shoulder girdle, you're just trying to get that one joint. You'll be applying traction to that and just holding that for several seconds. You relax. And then you can come back and you can reassess your patient's range of motion to see if it has improved. All right, and then next, we're going to go over elbow. So, elbow range of motion, you can have them do active, and then for passive, it's flexion, extension, pronation, supination. And then you'll also, for your osteopathic structural exam, want to check radial head glide. So anterior glide and then posterior glide. And remember, with posterior glide, it likes pronation, and then with anterior glide, it likes supination. So our treatment, best treatment for the elbow is our muscle energy. So if you have a posterior radial head, it likes pronation, doesn't like supination, so we're going to put it there and then have them try to pronate against resistance. Hold for 1, 2, 3, 4, relax. Further into supination, and again. And relax, okay? And you'll just continue that probably 4 to 5 times. And then you'll come back and you'll reassess. All right. And then we'll move on to wrist. So wrist range of motion is flexion, extension, AB, and adduction. And a good treatment for any wrist, like just general pain complaint, is the figure 8, which you learned it. You're going to come on either side of the carpal bones. You're going to add some compression. Oh, got you off the ground. Add some compression, some traction, and then you're going to move in that figure 8 position. If you don't really feel like you're getting anywhere with that, you can also find the carpal bones, add your compression where you need to, and then just take them through the range of motion. Another great treatment, especially for carpal tunnel syndrome, is that myofascial release treatment that we learned. And a good way to do this is by taking your pinkies and inserting them on either side. You want to add some slight wrist extension, and then in between your hypothenar eminence and your thenar eminence is where you're going to be applying that distraction force. You're going to distract out laterally. And remember, you're not just gliding across skin, you're actually adding compression to get down to that flexor retinaculum. Then you can come back, you can reassess, see if the tissues feel looser, ask the patient how their symptoms are, and then give them some home self-stretching. For documentation of all this, you would put your dysfunction in the objective portion. So if you had a wrist flexion dysfunction, that's where you would put that. And then for your plan portion, you would put your OMT that you did. So either that's myofascial release, muscle energy, or articulatory Spencer's technique. Thank you.
Hi guys, so this is the lower extremity video. This is the last of our OMT review videos. So we already actually talked about the hip joint, so I'm going to just briefly remind you to take that patient into their range of motions. That's going to be flexion, extension, internal, external rotation, and then AB and adduction. Then you can just apply your muscle energy principles to any asymmetry that you find there. One technique that we didn't talk about when we did a hip that is good for patients is the IT band, myofascial or soft tissue. To show this one, I'll have my patient lateral recumbent with the side that we're treating up. You can just have them kind of flex at the knee on the side that you're treating, and then just take your knuckles and roll down their IT band. If that's a little bit too much, you can just use the heel of your hand, going from the hip down to the knee. Again, just another IT band myofascial release. Waiting for that creep. So then to talk about the knee, our motions we have there is going to be flexion, extension, and then you also have a little bit of internal and external rotation. A big place that you want to evaluate when you're evaluating the knee is going to be the fibular head. So you can have your patient do a figure 8 with their foot in order if you're having a hard time finding the fibular head. The fibular head's right here, and when you contact it, you just want to push it posterior and anterior, looking for an ease of motion or a hardened feel. So some treatments for fibular head. If my patient had a posterior fibular head, that fibular head likes the foot in supination. So I'm going to put them into their restriction, which is going to be pronation, and I'm going to be kind of pulling up on that fibular head anterior, and then I would just be applying my muscle energy principles, having the patient try and supinate the foot against me. Then for an anterior fibular head, that fibular head likes pronation, restricted to supination. So I'm going to put them into supination and then contact that fibular head on the anterior aspect and then kind of pushing it posterior with my left thumb here. Then I'll have my patient resist me by trying to pronate the foot. And again, just applying your muscle energy principles. So the last kind of area we have is the feet. And since you can't really do HVLA on any standardized patient, you really just want to kind of assess your general ranges of motion. So plantar flexion, dorsiflexion, and then if you locked out the talus, assessing that calcaneus inversion and eversion. And again, a good thing to do here is just to use your muscle energy principles to apply to any asymmetry that you find there. So again, like all other joints and areas of the body, put your specific somatic dysfunctions in the O portion of your SOAP note, along with any other TART findings, and then whatever treatment modality you use, whether it be muscle energy, myofascial release, soft tissue, in the plan portion of the SOAP note. Thank you.